Hello, I am Simone Stein, manager of the Bone and Joint Center at Orange Regional Medical Center. I am here to talk to you about where to go, what to do, and what to expect before total joint replacement. I want you to follow through with the instructions, because if you're not committed to doing what you need to do, your outcome will not be what you want. So listen carefully and come along with us. I also want to say my name is on a badge, and every employee at the hospital does have a badge. So you will be able to identify people at the hospital as far as what they do. Mine says RN. You might find a lab tech that says lab, X-ray says X-ray. And you should expect, for your safety, to have everyone wearing a badge. First of all, I'd like to give you a little history about the Bone and Joint Center. We have been very lucky to have a physician help us develop our programs. Back in 2003, Dr. Ron Izraelsky, with his passion and desire to have orthopedics the best it can be in our area, so that you did not feel like you needed to go to New York City to have total joint replacement. During that time, Dr. Izraelsky and a team from Orange Regional went around the country to look at programs to find out what we wanted to do at our facility to have an excellent total joint program. Now I'd like to talk to you a little bit about the history of our Bone and Joint Center at Orange Regional. Dr. Ron Izraelsky has been an orthopedic surgeon, has spent a lot of energy and passion trying to get orthopedics to what we want it to be in our area. He wanted to be sure the people in our community felt comfortable about coming to Orange Regional to have total joint replacement. So programs at that time were set up, and we continue to make the programs better. We look at what best practices and implement these different processes so that you have excellent care here at Orange Regional. Currently at Orange Regional Medical Center, we do use Zimmer as our primary company to provide us with total joint and total knee implants. Currently we are around 95% use of Zimmer products. This is a Zimmer knee, and you see this is small. Some people say it feels really heavy. It's made of chromium and cobalt and titanium and plastic. And the doctor decides on what size implant to use for you by your x-rays and different measurements that they may be taking. So in the operating room, they have several sizes in there, and you can see the difference here in these two. This would be probably for a woman, and this is for a man. For total hip, this is the implant that I have here, but there are different products that are on these. This is metal, the metal ball, and the plastic. Some of the implants, these could be ceramic, this could be metal, this could be ceramic and ceramic, but mostly now, most of the implants are metal on plastic. Metal on metal we found to, we're not sure what those metal ions are doing in our bodies, so we don't do that. And we essentially don't use ceramic ball and a ceramic liner anymore because people were squeaking, and they actually made sounds like and that was very disturbing. So we usually use the metal on plastic. A lot of people ask me, how long does it last? Well, it depends on how you use it. A doctor put it to me this way one time, that if you drive to New York City every day, your tires are going to wear out faster than if you drive to Middletown for your surgery. So that's not to say not to use your joint. Your joint is meant for you to get back to the activities that you've always wanted to do. So use it. If you've got any questions about what implant your doctor is going to use, please talk to your physician. Some of the things I want you to be mindful of is that if you have a metal allergy, and usually it is to nickel, and you would know you have a metal allergy if you have reactions to your watch or earrings or a necklace, you developed a rash. I want your doctor to know that, so that he can get you an implant without nickel in it. So he needs some advance warning on that. If you're not sure, an allergist can do a skin test, but if you think you might, usually what the doctor does is order you an implant without that nickel. I also want you to tell your anesthesiologist if you're using a lot of pain medication, because that way we can perform better pain management with you after surgery. So you will be given a paper to list all your medications, and I want you to be sure to be precise on that so that the anesthesiologist can give you a dose of medication to manage your pain better after surgery. Also, if you use alcohol on a daily basis, we want to know that too. You also need to let your dentist know, and the reason for that is we worry about infection. When you have dental care, bacteria get released into your bloodstream, such as especially when your teeth are getting cleaned. So we want your dentist to know so that every time you have dental work, they will prescribe antibiotics for you to take. Some of the literature out there does say that in 2 to 3 years you won't need to do that, but after polling our physicians, they really feel that it's an easy thing to do and it will protect you for the rest of your life. You have a foreign object in your hip or your knee, and we don't want that bacteria to go there. Also, I want you to be sure that you have a healthy mouth before you come to surgery. Infections post-operatively are often caused from poor dental health. I would like you to see your dentist, and if you haven't seen a dentist for 10 years, you need to go see that dentist. You need to make an appointment, and at least a month out, but no less than 2 weeks before surgery. It is so important that that's healthy. Infections that we have seen are often caused from bacteria that are harbored in your mouth. So be sure that is so important. If you routinely go every 6 months, you don't have to do an extra visit, but be sure to let your dentist know that you are having total joint replacement, because they will ask you before your next visit, did you take your pre-meds? And if you didn't, they might not let you do that visit. So that is so important. Also, if your primary physician, you need to let them know what you're doing. You need to let them give you an opinion on what your risk for surgery is. Also, if you see a cardiologist, you should let them know, give you feedback regarding your health and what they think about that. During your pre-surgical visit, you will be seeing a physician that is certified in pre-operative medicine. And we started that a few years ago, realizing that a lot of our patients had physicians who saw things differently. One physician might order 100 tests, and another physician might order 2 tests. The standard of care for all of you was not the same. So fortunately, we had physicians that helped develop this program. It's a wonderful program, and you're all screened in the same way. We know that you are looked at in the same way. So we feel that's another safety factor for you. We're going to talk about the preoperative phase. You have or will be looking at our physical therapy exercise program, and I do see that patients who have done their exercises before surgery have a better outcome. They're better able to do their exercises. So I want you to be that person. I want you to do those exercises. And you must be committed to doing that physical therapy post-op. I've had instances where patients have had adhesions developed. I talked to them and I said, well, what went on with your physical therapy? And they said, I didn't have time. If you don't have time, you need to consider whether you really want to do this now. Without that commitment, you will not have the outcome that you want. And we all want you to have a happy life with this new total joint. When you go to the physician's office, they're going to give you an orange packet. In that packet will be a piece of paper. On one side of it, it will have a place for you to list all of your medications. I want you to be sure that that list is got all of your medications spelled correctly, that the dose is correct, and the frequency in which you take it is correct. I also want you to list any over-the-counter drugs that you take, such as ibuprofen, Advil and Motrin is an ibuprofen, aspirin, everything, even herbals. And the reason for that is that at pre-surgical testing, they need to look at your list of medications and decide on which medications you need to stop. Because a lot of these medications and herbs can cause bleeding post-operatively. So you may need to stop at 7 to 10 days. They will go over that entire list with you. They will give you instructions as far as what you should take the night before, the morning of, and when you need to stop everything. If you are on a blood thinner, you may need to be put on a bridge therapy. So let's say if you are on Coumadin as a blood thinner, that needs to stop at least 5 days pre-operatively, because it takes 5 days for that to get out of your system. Then, if your physician feels that you need that bridge, then you may be ordered a drug called Lovenox, which is an injection that's given into your abdomen daily until you come in. Now, that only takes 12 hours to get out of your system, so that we can keep you safe based on your need for anticoagulation. So that list is so important. Make sure that it is correct. Once that list is made, when you go to pre-surgical testing, the nurse there will put all of that information into the computer. Then, when you go to the hospital, all of that information is there for everyone to see. Your physician will reorder your medications for you. So don't worry about that. When you go to pre-surgical testing, which we would like 8 to 10 days before surgery, so that when they do the testing, if they find something wrong, then they can have time to fix it. Let's say if your EKG showed an irregularity you didn't have before. Your doctor may want you to have a stress test, and you can't go right from pre-surgical testing next door to have that test. It takes time to set that up. And that's very important, because we want your heart to be as safe as possible for surgery. Also, if there's something wrong with your lab test, then there's time to fix it. Let's say if you're on a water pill, such as Lasix, then if your potassium is low, which is often one of the things that could be low, there's time to fix that. Give you an oral prescription for potassium pills. Things like that. That's why we need that time before surgery. At pre-surgical testing, they'll be drawing your blood. You do not need to be fasting for that. They'll be doing an EKG. They may do a urine test, not always, and they may do a chest x-ray, not always. From that visit, the doctor and the nurses will work with you to come up with your pre-op plan. Again, you'll get that list from the pre-surgical testing area, and I want you to be sure to reread that. I want you to be sure that you know exactly what that says. I do not want you to go by memory. I did have a patient once that went by memory. She was on that bridge therapy we spoke of. She came into the hospital. She took that shot in the morning, and remember I said it took 12 hours for that to get out of her system? Her surgery needed to be canceled. So you don't want to come to the hospital and have your surgery canceled. So make sure you understand that. Also, if you have a coach, make sure that they go over all of these things with you. And it is a good idea to have somebody by your side to make sure that you understand things. Make sure that you do your exercises. Help you to get to appointments, that sort of thing. So bring that coach with you to pre-surgical testing if you can. Pre-operatively, I'd like you to start thinking about your discharge plan. I want you to think about where do you want to go for your therapy. And we will be talking about that later on in the PowerPoint. But I also want you to know what your insurance covers. I want you to know what your co-pays are. I've had patients that had a $50 copay every visit for outpatient therapy. If you know what it costs, then you can be financially prepared. You can also know what benefits you have. I had a patient come in once, and he had no physical therapy benefits after a total knee. You can't have total joint replacement without therapy. So I want you to know exactly what your insurance covers. Do you live alone? What kind of help do you think you need? When you call your insurance company, I want you to find out what your co-pays are. I want you to speak to somebody, not the receptionist at the insurance company. I want you to speak to a nurse or a doctor, and it would usually be a nurse. So anyway, know what your insurance covers so that you are prepared both emotionally and financially for your surgery. The night before surgery, they will tell you to be there an hour and a half or 2, and lately it's been usually 2 hours for you to come in. When you get there, you're going to go, first of all, I want you to arrive on time. That's really important, because if you start late, then that makes everything late and it creates a big hassle. So make sure you get there on time. The hospital, come in through the main entrance. It is a covered port if you haven't been to the hospital, and go into the main lobby. In that lobby is a central desk. I want you to go there, tell them who you are, and they're going to give you your name bracelet, and they're going to ask you to check the spelling of your name and also your date of birth. We use 2 ways to identify you, another way to keep you safe. So make sure it's spelled correctly, that your date of birth is correct. They're going to put the band on you. From that point on, anytime you get medication, anytime you go for an x-ray, before you have the surgery, anytime any procedure is done for you, they're going to ask you your name and date of birth. And we use 2 ways because we could have similar names in the hospital. From that point, they're going to point you to the same day area. Now that's not going to be where you're going to go after you're done with the surgery, but that's where all the process starts. When you go over there, somebody will, a nurse from the area will come and get you to start the process. Sometimes they allow your significant other, your coach, go with you, and sometimes not. So just be patient with that. Before that, though, when you do go and get your name bracelet, you will be given a card. It's a HIPAA card, and it's going to have a special number on it. That number is a number that you choose to give to family and friends, that if you're not able to speak to them, they could call the nurse, and the nurse will not give that person any information without that number. So make sure that the right people get that number, and you'll get that right away when you come in. Also, that number will be on a flat screen TV in the same day waiting area, and your family can follow you through your progress in the surgery. When your loved one goes into recovery room, the doctor will come out and find you as the coach or the significant other family member. Now, once you get into that same day area, they're going to do several things. They're going to give you a hospital gown. It opens up in the back. They're going to start an IV. And also, the night before surgery, I'd love you to drink lots of fluids so that you're well hydrated, so that those veins pop up really nice. They're going to be going over all of those questions and things that you did at pre-surgical testing. They're going to check to be sure nothing has changed so that your medical record is current. They're also going to ask you about an advance directive. So hopefully that will have been in your chart already, but if not, bring it along with you. They'll make a copy and put it in your hard copy chart. Once they're done asking all of those questions and getting you ready, you'll be on a stretcher. Then you will go to the holding area if you're a total hip patient, there, the total hip patient will see the anesthesiologist. They're going to discuss the kind of anesthesia you're going to have. You're going to see your surgeon because they're going to say to you, "What am I doing for you?" Don't be upset. That's how they have to ask that question. That's another safety thing that we do. The doctor's going to ask you, "Okay, Mrs. Smith, what are we doing for you?" And you say, "Hey, doc, I'm having my right total hip replaced." Then they're going to sign it. So they won't do the surgery unless it's signed. And there will be a final timeout in the OR, also in the operating room, where everybody in the operating room stops. Make sure that we have the correct patient doing the correct surgery on the correct side. So also you're going to see the RN that's going to take care of you in the operating room. They're going to put a nice little hat on you, and they may ask you some more questions that you've already answered a few times. So again, just be patient with that. If you're a total knee patient, you will be going to the recovery room because 99.9% of our total knee patients have a femoral nerve block to help with pain management, and we take you to the recovery room. You will see the physician there, and your physician will mark your knee. You will see the anesthesiologist because the anesthesiologist is the one that's going to speak to you about your anesthesia, and the anesthesiologist will also be putting in that femoral nerve block. You will see the RN that's going to take care of you in the OR because she or he will be assisting the anesthesiologist to put in that femoral nerve block. I will be talking about the femoral nerve block when we're talking about pain management. When you go into the operating room, I want you to be prepared. It's nice and cold in there, but they're going to make sure that you're kept warm. We have warm blankets. We've got a device called a bear hugger, and that is a nice disposable blanket with holes in it, and it blows warm air over you because we do want to keep you nice and warm. You're going to be in the operating room an hour and a half or two. They're going to do that timeout in there. They're going to put monitors on you so that they can monitor your heart. They're going to put a blood pressure cuff on you to monitor your blood pressure. They're going to put a little clip on your finger to monitor your oxygen level during the procedure. Then they're going to give you the anesthesia. And the majority of you will have spinal with sedation or spinal with general anesthesia. So the procedure itself only takes about an hour for the actual joint replacement. But remember, you'll be in the operating room an hour and a half or two because they need to do all of those things. They'll be also putting in a catheter. Most of our physicians do want you to have a catheter in your bladder. That'll be done while you're asleep. They'll also give you sedation while they're doing all of these things, so you're going to be happy or not caring. And that's a good side effect of those medications. So you're not going to remember much after they do that spinal or give you the general. And you're going to wake up on your bed because while you're asleep, they're going to take you from the operating room table to the bed. So that's a nice thing. You're going to go into the PACU recovery room on that bed where they're going to continue to monitor you. Now you're going to be there for at least an hour. That way they can make sure your blood pressure's okay, that your heart rate's okay. That's where we start managing your pain. With the femoral nerve block patients, that's when they put the medication on the IV pump so that that pain management starts right away in the recovery room. And by the way, if your family member or a coach can't stay, just let the doctor have a cell phone number or a home phone number, and the doctors will call your loved one after you go into the recovery room. All right, so once you're all stable and everything and ready to move, they're going to move you in the bed to the 4th floor. It's on 4 West. It's the bone and joint floor. And the nurse from the recovery room will give report and let the nurse know who's taking care of you all about you, what your vital signs were like, to make sure everything was, everybody's communicating everything that they need to know to take good care of you. If for some reason And some of you may know preoperatively, let's say if you've had a cardiac condition or you have severe sleep apnea, then the doctor may want you in the progressive care unit post-operatively to be monitored. In that case, it's usually just overnight, and then you would go to the bone and joint center after that. And nurses give report to each other all the time. We have huddles, and anytime there's a nurse change, everybody gets the report so that everybody knows all about you. I haven't mentioned this yet, but before I get into the post-operative experience, some of you may need blood. A couple of years ago, I did evaluate how many of our total joint patients needed blood, and it was about 17%. So not everyone needs blood, but there is a likelihood that you could need blood. Some patients have asked me about, what about donating my own blood? Well, we used to do that all the time. Recently, the physicians have felt and have told me that they think that maybe it just makes you a little bit more anemic before surgery if you've donated 1 or 2 pints of blood. But if you're really interested in that, I suggest that you speak with your orthopedic surgeon about doing that, and they will help you through that process. Now, I do want you to know that you need at least 2 weeks before surgery to do it, and not more than a month. 4 to 5 weeks is usually the amount of time that that blood can be stored. And then you want that at least 2 weeks to, make your blood a little bit stronger. Let's talk about your post-operative experience. Some of you may need blood transfusion. We will determine that as you will have your blood drawn daily for 3 days. We will look at the component in your blood called hemoglobin and hematocrit to see how you are tolerating your blood loss. If you should have a lower hemoglobin, and it depends on your health history, you may need the blood transfusion. You will need to sign consent for that, and the doc will go over, some of the risks of having blood transfusion. So you will have an IV after surgery. The fluids will run for as long as you need fluids, and the nurse and the doctor will determine that. But you will continue to have your IV site, which is hopefully here or here, until pretty much the day of discharge. That way we have IV access if you need any medications intravenously. All of you will have oxygen for up to 24 hours post-op or longer if you've got a respiratory condition. So, and it's usually done with a pronged, it's called a nasal cannula. It'll be right in your nose. And sometimes that tickles a little bit. All of you will have a drain either in your hip or your knee. And the drain is a sterile tube with holes in it. And this is the size that they use. And it is in there for 1 or 2 days. And it's attached to this thing. It's called a hemovac. It creates suction on the drain, and the blood from your knee or your hip is going to be collected in here. If you do 2 joints, then we do an additional thing where we collect the blood for 8 hours after surgery in this device. When 3 hours have come, or there's enough volume in here, then we drain that into this device. Then we hang it up, and through special filters, give it back to you. We only do it when you do both joints because your blood loss is twice as much as a single joint would be, logically, right? So anyway, this is only collected for 8 hours, and then we discontinue it, and then it goes to this, right to your drain again, just like everyone else. Also, this is an opportunity to tell you about your staples. All of you will have staples, and the hip incision is on the back part of your derriere, and the knee incision is down the middle of your knee. And the doctors use the smallest incision they can to get your implant in. You will also have your vital signs monitored very closely because of the anesthesia and the medications that you're getting. So I don't want you to expect to get a good night's sleep that first night because you won't. The nurses will be waking you up every hour for the first 8 hours, and then every 2 hours for 8 to 12 hours. So just be mindful of that. The following nights, you're not going to be disturbed that often, but this is a way to keep you safe. We have to make sure that your blood pressure is good, your pulse is good, and that your respiratory rate is good. I also want you to consider how, before surgery, remember, a healthy body heals better if you eat well. Well, that's the same after surgery. But because of the medications and the different things that we give you, because we're going to be giving you medications you didn't have before, we're going to give you iron to help build your blood back up. We're going to give you stool softeners because we're giving you the iron and the pain medicine. We're going to give you laxatives and calcium, multivitamins. So you're going to take a lot of things that you're not used to taking. Sometimes that can make your appetite not be so good. Some of you may need to have your iron stopped. But anyway, the doctor and the nurse will look at you and see how you're doing. If you are nauseated, there will be medication for that. So we're going to keep you as comfortable as possible. All of you will have a trapeze in your room, and it's a device that's over your head. It's like a U-bar, and it's there to help you to move. I want you to use that to help you to move in bed, because moving helps diminish complications. Moving helps your blood move. Moving helps your skin stay intact. Because let's say if you've got a burning sensation on your butt or your heels, that's an indication that the blood flow isn't there quite right. And what happens when blood flow isn't there, skin can die, and that's how a bed sore can start. So I want you to use that trapeze to help your skin as well. I want to have it help you move in bed so that you don't fall down in the bed. Make sure you use it. Some people do feel awkward the first time they use it, so we will show you how to use that. For hip patients, you're going to wake up with this abduction pillow splint. That's to keep you in hip precautions. Once you're awake enough, then we can undo your non-surgical leg, so that'll give you something to help you move in bed with. But if it's too tight, make sure you mention to the nurses to loosen it, because it doesn't need to be tight now that you're awake after the anesthesia. During surgery, you won't have ice or cold applications on your joint, but in recovery room, the nurses there will give you cold therapy. Make sure that you do have ice packs at home too, in the freezer, ready for you. Now, cold application can be anything. It could be peas and carrots. It could be corn. Somebody told me lima beans last longer. But if you decide to use vegetables for your cold therapy, I want you to mark it to make sure you don't eat that again, because you'll defrost it and freeze it, defrost it and freeze it. You can use ice chips. You can use ice cubes. But I want you to make sure that you watch for any frostbite. So make sure there is a barrier between the plastic and your skin. During surgery, most of you will have that catheter I had mentioned earlier. And I'm showing you this because I want you to understand the importance of it as a nurse. Like I said, not all of you will have it, and it stays in. The nurses in the operating room, while you're asleep, will put this in. And it stays in because they inject saline in a balloon, and that balloon stays inflated, and when we're ready to take it out, we just pull that out and it slides out. It doesn't hurt. Having this catheter in will make it easier for you. You won't have to get up to the bathroom or get up on the commode or use a bedpan, and I don't want you to use a bedpan if at all possible. But sometimes it's necessary. Let's say if your blood pressure is low or whatever. But anyway, for the first 2 days you will have this catheter, and we do take it out in 2 days, so that if you had surgery on Monday, it's taken out Wednesday morning. Now, as a nurse, I really like this because I can tell how well hydrated you are and how well your kidneys are working. If this is full of nice light yellow urine, I'm a happy nurse, and your nurse is happy, and your doctor's happy. If there's not very much in here and it's dark, maybe even brown, then we know that we need to have you drink more fluids, or even maybe call the doctor and see about increasing your IV rate or giving you a bolus. It will be attached to your leg with this little device, and that's so that the catheter doesn't wiggle. We found with research that's been done over time that if we keep it stable, it's not going to irritate the tube that goes from your bladder to the outside, and thereby decreasing your opportunity for an infection. Because we do worry about infection, that's why we take it out in 2 days. Also in your post-operative experience, during surgery, the nurse in the operating room will put one of these on. It's called a venous compression device. That's to keep the circulation going while you're in surgery. Once you're done with surgery, when you go into the recovery room, the nurse will put one on the other leg. If you're doing both joints, then they'll put it on the one that's not being operated on and then switch it over during the other part of the surgery. And then after surgery, you'll have both of them on. And how this works is there's a bladder in here, which is placed near the calf, around the calf, and it's put together like this. Then when both of them are on, they alternate. This will pump up, this will deflate. This will pump up, then this will deflate. And a lot of patients say it feels like they're getting a leg massage. So these stay on when you're in bed, post-operatively during your recovery time. When you're awake, then you're going to be able to keep moving your legs, pedaling your feet, curling your toes, doing all of those to help that circulation again. Also after surgery, you will be getting physical therapy twice a day, usually. Sometimes that doesn't occur, but it usually does. And we do have therapy for our total joint patients and orthopedic patients 7 days a week. So that's a good thing. You'll initially get up and walk out in the hall, may get some exercises. So the therapists are real good up there. They're going to be very helpful for you. So just look forward to doing that. Now we're going to talk about infection prevention. That's such an important thing to do, and what your role is in helping to prevent infection. First of all of you will be getting Hibiclens or chlorhexidine at your pre-surgical visit. They're going to give you instructions on how to shower with that. You'll be taking a series of 3 showers. You're going to be instructed on when to change the sheets on your bed, when to use a clean towel. It will all be written down. So don't worry, and I want you to read it and follow through with it. There's also a checkoff list to make sure that you do it. You will be getting a nasal swab, and we are testing you for staph. Staph is a germ that can cause infections, and we look for the methicillin-resistant staph, which is MRSA, which I'm sure you've heard of, or the sensitive staph, which is MSSA. If you do have that bacteria in your nasal passages, it doesn't mean that you've got an infection. It means that you're a carrier, and we want to get rid of that. So if that occurs, then you will be given a prescription by your orthopedic doctor for ointment for your nose. It's usually called Bactroban, and you'll need to put it in your nose twice a day. And those would be the days before surgery, none the morning of surgery. So it'll be a 5-day treatment. I also want you infection-free. If you come to the hospital with an infection, you can count your blessings that the doctor will not do the surgery. You do not want to have an infection of any sort prior to surgery. Let's say you have a urinary tract infection. You wake up in the morning and it's burning and frequency with urination. You don't want to have surgery. You don't want that bacteria to go into your joint. If you've got an earache and you're running a fever, your surgery will be canceled. So any infection that you have, your surgery will be canceled, and you'll want that. So you need to be infection-free at surgery time. Pre-operatively, you'll also be given antibiotics within a half hour to an hour of your incision time. You'll also be given antibiotics post-operatively. Anybody working on you, your doctor, the technician that's handing him the instrument, and your doctor's assistant, they have a space suit on. That space suit is such that no hair or skin is showing anywhere, so that there's nothing in the air around your joint at all. So that's another way to protect you. Your leg is going to be scrubbed. It's going to be scrubbed from your waist all the way down to your toes. So when you wake up, your leg could be brown, yellow, pink. Anyway, that's the antiseptic that they use to scrub you down with. They also use drapes so that only the part that they need to have exposed is exposed. Also, I would like to ask you to buy yourself some hand sanitizer so that you as a patient have a hand sanitizer at the bedside. In the hospital, there's hand sanitizers everywhere. Nurses, doctors, visitors, everybody can wash their hands as they come in, but you're in the bed or in the chair, you don't have an opportunity to wash your hands. And it is 20 seconds. You need to have enough solution to make it take 20 seconds, and I want you to be mindful of your fingernails. And speaking of fingernails, fake nails are a no-no. They harbor a lot of bacteria. You can't really get them clean. And I know for those of you who love your fake nails, I want you to really consider getting rid of them for surgery. In the hospital, you're going to have a dressing on your wound, and you should keep the dressing on until everything seals up. If you are draining, and some of you may drain, and it doesn't mean that you've got an infection, it's a clear pink drainage or a clear yellow drainage could be there. If you do have that drainage, I want you to be sure to keep it covered in the hospital or even at home when you go home. This is the dressing that we use if you're not draining very much. If you are having some drainage, we may need to use a larger dressing. But this is nice until your staples come out, and staples come out in 8 to 14 days depending on how well you're healing. And I don't want you to wait too much longer than 14 days because the skin will start to grow over them. When you shower, and the doctor will let you know when you can shower, each doctor is a little different. Some doctors say 3 days, some say a week. So make sure you understand before you leave the hospital when you can shower. So if you do shower, I'd like it to stay covered. And then when you're done, you can take the wet dressing off. Pat it dry, no rubbing of the incision, and that'll keep your wounds safe. We don't want you to shave your legs either before surgery because shaving with a razor cuts the skin. It's an opportunity for bacteria to get underneath there. In the operating rooms now, we don't shave people anymore. We did many years ago. Again, we found out that that could increase the risk for infection. So they use clippers in the OR if your legs are really hairy, or you can use a depilatory such as Nair, something like that, as long as you don't get a rash from it, or an electric razor. You can use that, but no straight razors for a week prior to surgery. Smoking increases your risk for infection. Smoking increases your risk for a lot of things. But in the hospital or on the hospital grounds, there's no smoking. If you are not able to quit, then we can get an order for a nicotine patch or nicotine gum from the doc. So be sure that you let the nurses know if you need that. Showers, tub baths, and swimming, that's all based on what your doctor has to say. And remember that dental cleaning pre-op. That's really important. And remember also with your dental cleaning that you're going to continue for the rest of your life to take antibiotics prior to those visits. Also, if you're having like a colonoscopy, one of the questions on the doctor's questionnaire for you will be, do you have total joint replacement? If you do, they'll give you IV antibiotics because during a colonoscopy you're not supposed to eat, so they wouldn't want you to take the pills. But just know, before any invasive procedure, people will be very aware, and it's your role to make sure everybody understands that you've got a total joint replacement. Signs of infection would be more pain, more swelling, more redness, fever, anything over 100.8, and drainage that is not clear, pussy kind of drainage. So if any of those occur, you need to call the doctor right away to get it treated. Sometimes some of you may have some redness, and the doctor may say, well, it's not really infected, but let's just put you on an oral antibiotic for 10 days. That is an important thing, and then that'll be the end of it. And I do want you all to know that you will all have pain, swelling, and maybe some redness. So it's more pain, more swelling, more redness that you would need to call the doctor right away. And I want you to be mindful too, when you go home, get your legs up, because patients, I have found that when you go home, you seem to be up more, so the swelling is more. You need to get that leg above the level of your heart. Get some pillows underneath there, get it up, pedal your feet to get that swelling down. Now we're going to talk about your anesthesia. Most of you will have a spinal, and I have to tell you, I am a proponent of this spinal. Knee patients, you're going to have a spinal along with sedation. Now, sedation won't put you all the way to sleep, but it should make you so you don't even care, and you'll be sleeping. Let's say if the anesthesiologist were to touch your arm and say, "Hey, Joe, what you doing?" You might wake up, but other than that, some patients even snore in the operating room. If you're a hip patient, you're going to have a spinal along with general anesthesia, usually. And the reason why the hip doesn't have sedation is because during surgery they have you on your side with your arms and you're wedged in so that your surgical hip is up for the doctor to do the surgery. And then your arms don't quite know where to go. So anyway, to keep you asleep and not restless because of your arm position, essentially, then they give you a little general anesthesia. And you do need less general anesthesia when you have a spinal, so you won't be as groggy as if you were just having general. Also in that spinal, they put in a long-acting pain medicine called Duramorph, and that will help manage your pain after surgery for 18 to 24 hours. Now, with the spinal, most of you will get that for your anesthesia, and it's going to make you numb from the waist down. So when you wake up in recovery room, when you can't move your legs, I don't want you to think, "Oh my God, I'm paralyzed." Well, you are for about an hour after surgery. It takes about an hour for that to wear off. But guess what? You're going to wake up in zero pain. All right? And that's a wonderful thing. Most of you probably haven't felt that ever or in many, many years. So that's really a good thing because you're going to start out in that zero pain. And then the nurses in the recovery room can start medicating you as you start feeling pain. So that's a wonderful thing, and that's why I am a proponent of that instead of general. Now, if you can only get the general, that's not such a bad thing. You're going to be totally asleep. They'll have a tube in your throat to help you to breathe. And then for your pain management, when you wake up, they will probably start through anesthesia orders to give you what's called a PCA. Now that means patient-controlled analgesia, and it's a machine with either morphine or Dilaudid in it, which are strong narcotics, to help you manage your pain. You will be given a button to push, and you can medicate yourself with that. And the anesthesiologist will give us parameters to make sure that you don't give yourself too much medication. If you do have that PCA, it is very, very important that you be the only person that pushes that button, because you need to be awake enough to push that button. If your family members or your friends say, "Hey, do you need something for pain?" and push it, you could get overdosed, and we certainly don't want that to happen. So only you as the patient can push that button. With the spinal, they're going to have you sit on the side of the operating room table. They're going to cleanse with an antiseptic your lower spine. They're going to numb the area. And usually as they're doing that, they're giving you some nice happy stuff in your IV so that you don't remember anything after that. At least that's what patients tell me. So they're going to have you sitting on the side of the table. They're going to have you lean forward. They'll probably give you something in there. There is somebody in front of you. And then the anesthesiologist will have access to that catheter for the duration of the surgery. You will not wake up with a catheter. The side effects of anesthesia, you can get nauseated. We have medication for that. You could get itchy from that Duramorph. It's a morphine-based drug, and it can cause itchiness, but usually what I see is somebody just doing this with their nose post-op. Sometimes you can get a little itching on the skin, and the anesthesiologist will order medication for that intravenously, usually Benadryl. You could get dizzy, and you could have that sore throat if you have that general anesthetic where they breathe for you during surgery. Your blood pressure could be low, and your respiratory rate could be low. Now, the most common side effect that we do see is a low blood pressure within that first 8 to 10 hours. So anyway, sometimes that means that you need a few more fluids, and that's why you need your vital signs taken frequently, so we can watch that. Another side effect could be sleepiness, and you could be forgetful, but that forgetfulness, most people tell me they like that. All right, pain management. I know this is of concern to all of you who are having total joint replacement. And Orange Regional has done a lot within the last year or two to help manage pain. Now, with total hips, what I find is that a lot of our patients describe the pain as, oh, it feels sore now. It feels really different from that crunching, snap, crackle, pop they used to have before. And they know that it's going away. So emotionally, people seem to be dealing pretty well with the post-op total hip post-operative pain. However, there are medications that can be taken if you have a little bit more pain than that. But I do have to tell you that a total hip pain is a lot less. The doctor will order pills. You may need something IV for that first day, but I do find that more often than not, the pills work better than any IV medication does. So the nurses will work with you in regards to that. For the total knee patient, we're doing the spinal with a Duramorph. So you're going to wake up with no pain. Remember, that's a wonderful thing. And we're also doing that femoral nerve block. Now remember, just a little while ago we talked about going to the recovery room to see the surgeon to sign your knee and to do all of that. Well, the anesthesiologist will discuss your anesthesia with you, and they're going to do the femoral nerve block there along with the operating room nurse. And you're going to be on a stretcher. They're going to have you lying down, maybe your head up just a little bit. They're going to clean off your groin area on the same side as your total knee is. They're going to numb it up. And usually about that time, they're going to give you some sedation. So again, you're not going to care, or you'll forget what it is. So they use an ultrasound wand, which has got a TV screen about the size of a computer screen. And they have a wand that they put in the groin area to locate the femoral nerve. And they have that needle there. Now remember, you're all numb. They're going to put that needle until they find the femoral nerve. And when they find the femoral nerve, your knee's going to twitch like that. It's very rhythmic. So the doc wants to see that. Don't worry, that's what he wants to see. Once he finds it, he's going to thread a catheter in that area, and that twitching will stop. And they're going to put a dressing on the groin. They're going to tape again on your tummy. They're going to cap that off so that when you get into recovery room, the nurses there can put, it's an IV bag, it's called ropivacaine, and it's put on a pump so that it bathes that femoral nerve. Now, that's a wonderful thing, and it takes sometimes a little while. Like I've seen in about an hour, it's really starting to work really well. So you're going to be numb from the waist down initially. They're going to start that, so hopefully your pain management is going to be wonderful. If it isn't, though, you need to communicate. So with that femoral nerve block, it takes care of about 80% of your pain. And that's a good thing. But the femoral nerve doesn't work on the back part of your knee. So that if you feel pain, that's usually where patients tell me they feel the pain. Now, there will be other medications on board that the nurse can give you. And there's a whole gamut of medications. Some of you may be on Tylenol around the clock, and you don't have to ask for it. Some of you may be on OxyContin twice a day, 10 or 20 milligrams. Some of you may be on Celebrex and Neurontin. Neurontin is kind of a nerve inhibitor kind of drug that interrupts the transmission of pain. Anyway, there's a whole bunch of things, and different doctors order different things. But one thing I want you to remember, if it doesn't work for you, you need to let the nurse know. I don't want you hiding and crying and being upset with pain. We've got plenty of things that we can do to help manage your pain, but you need to let us know. Some people hide their pain well. Other people are loud enough where we can really hear that you're having pain, but please communicate with the nurses about managing your pain. And we're going to measure your pain on a scale of 0 for no pain and 10 being unbearable pain. And I don't ever want to see any of you in a level of 10 if we can help that. So your role in that is when, okay, like you're in the recovery room and you're no pain. When you get to be a 2 or 3, you need to start communicating with the nurses about your level of pain. And the nurses will be asking you too. So they'll give you something. Now remember, if it's IV, in 15-20 minutes you should start feeling the effects of that, maybe sooner. And if that's not working, let the nurse know. I do want you to know that you're not going to be in 0 pain. You've just had your joint replaced. There is some kind of pain that you will need to be aware of. But we want to manage it. And the management of it is a team effort. And you are part of that team. Also, remember, ice is your best friend. When you have pain, I want you to think first, cold therapy. Let me do that, because it's going to take the nurse a little while to go get your medicine, bring it into you. Unless you have that PCA, if you're that person. But communicate about the level of your pain. Again, if what we're doing isn't working, you need to let us know. If you have a high pain threshold, that's great. If you've got a low pain threshold, I feel bad. But anyway, we're all different individuals. We all cope with pain differently. Other than ice, remember, ice is your best friend. I don't want you to ever forget that. Medication, and we'll get a medication that works for you. If we have to, we'll call the doctor. Anesthesia is available 24/7. So if at 4 a.m. what we're doing for you is not working, we'll call the doctor. So we've got medication and ice. We also have other things that we can do. There's diversion. So if you've got an MP3 player, or if you've got an iPod, program it with some nice music. I don't mean hip-hop kind of stuff, so I mean relaxing kind of thing. The noise, it will obliterate any hospital noise, but it will also put you in another place, and you can visualize yourself. Diversion is another thing. So watching television or reading a book, that sort of thing is helpful as well. We also have an opportunity to provide you with something very special. It's called Reiki therapy, and it's a wonderful thing that takes about 40 minutes, and they work with your energy fields. It helps you to relax, and it truly does help a lot of our patients manage their pain. So if you want that, you need to let me know. We will get all of the process in place to do that, or let the nurse practitioner know, or let one of the nurses on the floor know that you want that. And that would be given post-operatively. Now we're going to prevent any blood clot formation. Remember, we talked about these Venodynes, or venous compression devices, being applied in the operating room and recovery room, and that you'll be wearing these. Also, I want you to move as much as you can. Remember, I said moving helps to decrease complications. It helps to prevent blood clots. So I want you to use that trapeze. I want you to get up out of the bed, with help, of course. I want you to move, move, move. Pedal your feet, crunch your toes, move your arms. Move, move, move. That's going to help. I also want you to drink lots of water. That's going to help more than your blood. It'll help for constipation and hydration and general well-being. But drinking that water kind of gives you more blood volume, so that would be thinner. All of you will go home on some sort of a blood thinner. Whether it might be Lovenox, it might be Coumadin, it might be Xarelto. On some occasions, really young patients are put on aspirin, but make sure you understand that completely before you leave the hospital. We will give you printouts about your specific anticoagulant. Make sure that you do understand it. Coumadin you need to watch what you eat, because vitamin K foods can alter how effective it is, and you need to get labs drawn 1 to 2 times a week with the Coumadin. If you're on Xarelto, which is a fairly new, approved by FDA drug that we just started using recently, that does not require food restrictions, and you don't need your labs drawn. And you take it for a short time. But you could be on anticoagulation anywhere from 12 days to 6 weeks. So your doctor, before you leave, will decide. Some of you, your doctor may order a Doppler, or it's called an ultrasound of your lower leg, as a precautionary measure before you leave. So don't be surprised if you get that, and don't let that scare you. For all of us, so tell your family members, when you go on a plane ride, you are at a risk for developing a blood clot. So I want you to be mindful of that when you go to the airport. Once you get past security, I want you to get a big bottle of water, because you know the stewardesses or the attendants there give you 1 cup of water every 2 hours. I want you to drink more than that. And I want you to pedal your feet when you're there. And if you drink lots of water, you'll have to get up and use the restroom a little more often. So it's going to make you move better. Also, if you're on a long car drive, I want you to be mindful of doing that to help avoid any blood clots during a long car ride. You get up, stop the car, get out, walk around, and move around. We're going to prevent pneumonia by moving. Remember, move, move, move is what you need to do after total joint replacement. So moving is going to make you take some deep breaths. Using that trapeze is going to make you take some deep breaths. Also, we have this toy that we give you, and I want it always to be within your reach when you're up in the chair or in the bed. And it's a toy that you inhale in, and we'll show you how to use it when you're at the hospital. But it's important that you use it 8 to 10 times every hour, and I'd like you to take those deep breaths consecutively, one right after the other, so that the air gets down in your lungs lower and lower. And there's a little button here. We're going to show you how to keep it there, and that might be a little bit difficult the first couple of times you try to use it, but keeping that button between those 2 arrows, it's going to make you use this properly. It's going to make the air go into your lungs in the right way. And then when you're done with those 8 to 10 breaths every hour, I want you to cough 3 times. That coughing will get up any mucus out of the lungs, and I want you to spit it out. Mucus is a great place for bacteria to grow, and bacteria in mucus in your lungs is called pneumonia. So you don't want that. Smokers are at higher risk for developing pneumonia post-op, so another good reason to stop smoking. And when we talked about oxygen use, all of you will have oxygen for up to 24 hours post-op. All right, one of the last things I'm going to talk about is constipation. We're going to be giving you iron to help build your blood back up. We're going to be giving you narcotics that's going to slow your gut down. Your fluids are going to be a little bit off, so you won't have as much fluids in your intestinal area. So anyway, and your activity is less than you normally would. So we worry about constipation. So we have a bowel regimen for you. And if that bowel regimen, which includes stool softeners 3 times a day and a laxative, if your bowels haven't moved in 2 days after surgery, we need to do something about it. And that could include a suppository. Also, if you've got a history of constipation and your bowels didn't, maybe you don't have a movement every 2 or 3 days, I'd like you to take a laxative 2 days before. It takes a laxative 12 to 24 hours to really work. So let's say if your surgery's on a Monday, on Saturday night, I'd like you to take a laxative, especially if you're prone to constipation, because being constipated is very uncomfortable, and it's better if you can go on your own. So if you do have that history, let us know what you take to help you through that, and we'll get that ordered from the doctor. All right, discharge planning. That's an important thing. Remember we talked about that earlier? I want you to think about that before you come to the hospital. What would you like as your discharge plan? I have to tell you that the majority of the nation does go home with home health care after total joint replacement. However, there are other options. Inpatient rehab, and Orange Regional has a wonderful inpatient rehab unit, but not everybody gets in. Several years ago, Medicare made rules about who could get into inpatient rehab. So a total joint patient can get into rehab if you're 85 years of age or older, if you do 2 joints at the same time, or your body mass index is 50 or greater. And what that means is that your body fat is at a 50% of your body weight. So let's say I'm 5'2", I would need to weigh 267 pounds to qualify. All right, so those are the three things that could make you acceptable under Medicare rules to get into inpatient rehab. And Medicare makes sure that all patients follow that rule. If you're private insurance, you need to meet Medicare rules, plus your insurance needs to approve it. So if you want inpatient rehab, number one, make sure your surgeon knows. What he will do is write an order for a rehab physician to see you, and the rehab physician will talk to you about the ability of, do you qualify, and is there room in the inpatient unit for that 40% that don't need to qualify. Then your name will go on a list if you do qualify. If you're private insurance, that will be researched to make sure that they will cover it, and then you'll be transported on the east side of the 4th floor to our inpatient rehab unit. If you do get there, you'll need to get dressed. You need shoes and socks, underwear, all the things that you would need at home. Most of the rooms there are private. There are 4 rooms that are semi-private, and often they like to room patients that have total joints in the same room. It creates a nice little competition and a little bit of things that you have in common. Your second option will be subacute rehab. Now, when Medicare made all these rules, it's been about 8 or 10 years ago that rehab made that rule. I don't know if you noticed, but a lot of the skilled nursing facilities started putting up signs at their rehab centers. And that was their response to Medicare's rule about who could get into acute rehab. In the nursing homes, that's called subacute. So these nursing homes developed short-stay programs for patients such as total joint patients. And some of the programs are really good. And we have several good skilled nursing facilities in our area. If you think that might be one of your options, I suggest that you drop in and say hello over there and ask to see the therapy department. Ask them about how it all works in that facility. And that way you'll get your rehab. Now, in those areas, in the skilled nursing facilities, subacute, rehab is during the day also, and it's 6 or 7 days a week as well. So as Medicare made these rules, skilled nursing facilities made programs that are quite good. And you're there, by the way, if you get into inpatient rehab, you are there 7 to 10 days. If you go to subacute, I've seen patients there 1 to 3 weeks is typical. Could be less, could be more. And how that works is that we have a case manager at the hospital who you will meet regardless of your discharge plan, who will talk to you about what you want and help arrange that. So this person will make sure that they talk to you about what nursing homes might have beds, and then they do paperwork that they send out. Also, make sure your insurance approves it, and then you could go to that skilled nursing facility. She will arrange transportation, whether it be by ambulette or family member, to that skilled nursing facility. Your third choice for your discharge plan would be home, with home health care coming to you, and that would include physical therapy. And like I said, the majority of the nation do choose that as their discharge option. So again, the case manager will help arrange that. There are several home care agencies in the area that some of them have liaison nurses that will come and speak to you at the hospital, and they'll make arrangements for a nurse to see you and a physical therapist to see you. Some of you may also want a home health aide. They'll talk to you about all of those services. When you do go out with home care, the home care agencies that we refer to have been excellent about providing therapy in a timely manner, or you could go home and do outpatient therapy. There are a lot of great outpatient therapy. We have a great outpatient therapy department at 110 Crystal Run Road. So anyway, you can even arrange that before. What you could do is, I'd like you to visit some of these facilities. Therapy offices closer to home, you're more apt to be willing to go to these places if they're close to you. If you have to drive an hour to go 3 times a week, that may be an issue for you. And what I want you to do is have the therapy. So take a look at the therapy offices. Ask them about their physical therapy program. So the purpose of post-op care is to get you strong and to have that miracle happen, because when your total joint works well, your pain is going to be gone, you're going to be able to do the things that you haven't been able to do for a long time, and you're going to be a happy camper. Some of the follow-up care I want you to be mindful of: if you go home on that Coumadin, that blood thinner, I want you to be sure that you know which physician is going to look at your lab tests and make a decision as far as changing the dose if you need it. I want you to think about help at home. You're certainly going to be able to take care of yourself somewhat, but you're going to feel tired. You will have lost some blood and will have had a lot of medications and that sort of thing. So help at home for that first week might be a good idea. For a physician appointment, depending on where you are, remember staples come out in 8 to 14 days. So if you're in the hospital and in patient rehab, then your physician may stop by and do it, or the nurses can do it. Get those staples out. If you're at home, you'll need to make an appointment to see your doc, and your doc will need to see you usually around 10 to 14 days post-op. One thing I do want you to keep in mind, that you need to have an orthopedic surgeon in your life, your doctor that's done your new joint. Will want to keep an eye on it, and you should have a visit with them every 2 or 3 years so they can keep an eye on how well you're wearing it out. So make sure you have a relationship with your orthopedic surgeon. If your surgeon should move, then you need to get another orthopedic surgeon to keep an eye on that. Or if you should move, make sure you find an orthopedic surgeon in your area. It's so important to keep an eye on that. And now just a few tidbits. You will get an implant card from the doctor on your first post-operative visit. So if they forget to offer it to you, don't forget to ask for it. And then you can put it in your wallet. And I have to tell you, when you go to the airport, you will set off the alarms showing the security people that card's not going to make any difference. They will wand you, so just prepare for that. So give yourself a little extra time going to an airport. Unless you know they've got that new machine that, you do this, you won't need to be wanded in that case. So just be aware of that. If you go to a courthouse, you'll also set off the alarms, and the card probably will be sufficient for the security there. Sex after total joint replacement. Total hips, you need to make sure that you follow hip precautions. With total knees, you don't worry so much about precautions, but positioning may be an issue. We will give you a booklet at the hospital if you're interested in that. If you don't already have one, a handicap sign is available to you. How you get that is through your orthopedic surgeon. They have the forms. You go to the office, they'll give you the form, and you take it right to the town hall, and they'll give it to you right away. One thing I want to caution you about, though, don't forget to take and it's usually a red one, off your rearview mirror, because that is a fine if you get stopped and it's there. So I guess that's all I have to say, and thank you for listening. And again, if you have any questions, feel free to call me. Sometimes after time, the plastic part in the total joint does wear down. You will need to see your physician every few years to keep an eye on that. And they last anywhere from 7 to 22 years. Sometimes a little bit less. There's an occasional loosening. Some patients do experience a little loosening. It's rare, but it could happen. But usually between 7 and 22 years, I've seen it. Yes, you will be in pain. We will manage it, though. So I want you to communicate with the nurses about your pain. And how long depends on how soon you heal. It's very individual. But you can expect pain on and off for a few months. and you'll have swelling maybe for a few months that would influence your pain level. You're going to be able to walk right away. The next day, physical therapy will come and walk you at least from the bed to the chair, maybe out in the hallway. Addiction certainly is a possibility. It doesn't happen that often, but if you start taking your pain medication because you like the way it makes you feel, then you might want to consider discussing that with your physician. You will need to communicate with your doctor about what he or she likes for you to do with that. After everything heals, the doctor may allow you to use Mederma or Neosporin, any of those things that might be able to help. That is also determined by your physician. Anywhere from 3 days to 7 days is the initial shower, but check with your physician. The surgery itself takes only about an hour, sometimes a little bit less, but you'll be in the operating room an hour and a half or two. The average length of stay for you in the hospital is 3 days. Yes, your length of stay will be longer. If you go to the inpatient rehab, which is right there in the hospital, the average length of stay there is 7 to 10 days. You will need a walker for sure, and a commode. You may need a shower bench or shower transfer bench. There are many community resources that can provide you with equipment. Many of the firehouses in your community, the local organizations such as the Legion or the VFW or the Knights of Columbus, you can find many of these resources in the phone book or online. Case management at the hospital will be sure you have the equipment you need before you leave. Most insurance companies do pay for your walker. The other equipment, such as the shower bench and the commode, they may or may not pay for. However, you will be working with our case manager, who will be working with you to provide the equipment that you need. Yes, there is always that possibility that you can donate your own blood. However, I suggest that you speak with your orthopedic surgeon, because donating your blood is time sensitive, and also it could make you anemic. So check with your orthopedic surgeon to get their opinion on that. You may or may not need blood after your total joint replacement. About 17% of our patients, when I measured that a couple of years ago, needed blood transfusion. Yes, you will set off the alarms at the airport. However, the doctor will be giving you a card that you can show to them, but most likely you will get wanded at the airport. So give yourself extra time when you're going on an airplane ride. Yes, your family member can stay with you at night if you desire that. What you will need to do is speak to the charge nurse, and they will let security know that we have an extra person in our house. There are directions on our website, which is www.ormc.org, and it will give you specific directions how to get to the pavilion, the class, or the hospital. Your staples will be removed 8 to 14 days after surgery. The first visit will be within 10 to 14 days after surgery, unless you're in the hospital in rehab.